We're going to turn our attention now to the treatment of a patient who is a little bit older and perhaps not a candidate for high-dose chemotherapy and transplant. I'm going to start with you, Dr. Jagannath. What have you heard at the ASH 2014 meeting about treating a more elderly patient?
There were at least two studies that caught my eye. One of them was comparing melphalan, prednisone, thalidomide, followed by thalidomide maintenance versus melphalan, prednisone, lenalidomide, followed by lenalidomide maintenance. This was the Nordic group.
Right.
I was not surprised with the fact that people could not stay on thalidomide maintenance long, so they actually came off the maintenance therapy earlier, and not surprisingly, it was due to neuropathy, numbness in the feet. But I was a little bit surprised that the lenalidomide arm, where the patient was able to stay on it, tolerated it longer, did not come out much better. And I would be open to hear what my colleagues thought about it.
Right.
Then there was this another study which reminded me of Sid Salmon's Sequential and Syncopated, if you remember, in the 1980s.
I'm not old enough to remember that.
You
go ahead, okay?
I'm old enough to remember that. So in the Spanish group did a trial alternating MPV and lenalidomide dexamethasone, alternating them. And the other one was finishing up all treatment up front, followed by lenalidomide dexamethasone later on. And initially, last year, they thought giving the alternative approach was superior with better response and things like that. But this time when they came back, it was all absolutely virtually identical in terms of overall response, the duration of response, and things like that. So these were the two.
It did look, in that latter trial, it did look a little bit to me like if you had started, it didn't matter whether you sequenced them or they were sequential, but if you incorporated both an IMiD, lenalidomide, and a proteasome inhibitor, bortezomib, it did seem to perhaps be a little bit better than a trial we're going to talk about in a second, which was the use of lenalidomide dexamethasone alone. Was that your takeaway, or did you not see that?
Well, the way I understood it is, of course, this is all a major progress since the era of melphalan prednisone in elderly patient. Now we are talking about, in almost all the studies, 1/3 of the patient, 30% are over the age of 75 in these clinical trials coming out of Europe and even in States. So that is very remarkable that the patients are coming on clinical trial, which tells you we are able to give these novel agents in a tolerable, and they tolerate it better. Most important is there is tremendous improvement in life expectancy in the elderly patients, so that was also very remarkable. And Shaji had published, reported it on that Mayo. So that is what, but I couldn't tell whether the first trial results I thought would have been comparable with this melphalan prednisone, backbone regimens. I don't think the first trial would have, RD alone would have fallen short.
You think so?
Yeah.
Well, you mentioned Dr. Kumar, who's here over here. Dr. Kumar, what did you think of the first trial? Maybe you could just explain to the audience what the first trial was and what it showed.
Right. So the first trial it's probably one of the biggest randomized trial that's been done in multiple myeloma. Over 1,500 patients who were randomized into 3 different arms. So going into the trial, one of the standard of care regimens have been the combination of melphalan, prednisone, and thalidomide. And this trial design was basically looking at the lenalidomide dexamethasone combination against melphalan, prednisone, thalidomide combination. However, the trial also had the lenalidomide dexamethasone given in 2 different fashions, one for a fixed duration of 18 months, and the other one the patients would continue until the disease came back. Now, we already heard the early part of these results last ASH and was subsequently published in New England Journal of Medicine, showing that giving the lenalidomide dexamethasone in the older patients continuously until the disease came back was superior to the older way of using melphalan, prednisone, thalidomide as the initial treatment for myeloma. So the data from this ASH is clearly building upon or the long-term follow-up of what we heard last time. And I think the most interesting part was specifically looking at the older patient population. That was a focus. And I think it's encouraging to see that even the over 75 age group patients clearly had an advantage by being on lenalidomide dexamethasone continuously compared to the melphalan, prednisone, and thalidomide.
So we have melphalan-based backbone regimens, melphalan, prednisone, bortezomib, melphalan, prednisone, thalidomide we just heard was somewhat toxic, and we have this lenalidomide dexamethasone regimen. And I know there might be some difference of opinion on the panel, but I'm going to start with Dr. Berenson. And how do you treat a 80-year-old patient with myeloma who walks in the door today? What's your go-to regimen, and what do you base that on?
Well, I would tell you that age is only one of the factors here. There's physiologic age. Right. There's obviously comorbidities. So when I treat a new patient, I'm taking disease characteristics into account. I'm also taking the patient's comorbidities and their life and work style. All these come into play. But an 80-year-old, I have many 80-year-olds that are pretty robust, so that in and of itself is not really that important. That patient may be quite similarly treated to a younger patient.
Let's say this is a healthy 80-year-old. You would use what kind
I
of
would
regimen?
generally use in that population either Velcade-based therapy with, if it's lower risk, dexamethasone or Cybor-D, but modified lower dose side.
And you use lower doses of all three drugs? Or,
yes,
no?
yes.
And what bortezomib dosing would you use?
We have always used, based on our preclinical modeling and published, that 1 milligram and 1, 4, 8, and 11, 28 days. Our neuropathy rates are very low.
Intravenous or subcutaneous?
Well, we certainly did use IV and now tend to use only sub-Q.
Is that true for everybody around the table?
Yes.
And Dr. Lonial, how do you treat an 80-year-old frail patient, let's say?
Yeah. So, I mean, I think the doublet, triplet discussion in a frail patient is a little bit tougher to go through. And so using Lendex based on the first trial, I think, is certainly a very reasonable choice. Actually, at ASH in 2014, the group at MGH presented data on what they called RVD Light. And the RVD Light regimen uses weekly dosing of bortezomib with lower dose of len and lower doses of dexamethasone. And they seem to be able to get those patients through that relatively well, even in an older, frailer population.
Okay, I'm going to try an experiment here and see if it works. I'm just going to ask you in one sentence, tell me how you're going to treat the next patient you see that is 80 years old and is in not the best of health. Let's start with you and we'll walk down the table here. Dr. Kumar.
In an 80-year-old with standard risk multiple myeloma, I would treat with lenalidomide dexamethasone. And in high-risk patients, I would treat them with a combination of Velcade, Cytoxan, and dexamethasone, but starting at a lower dose and seeing if we can go up on the doses.
Okay, let me ask Dr. Zonder, anything different than that?
Yes. So for a standard risk patient, I agree, lenalidomide and dexamethasone, the doses of each probably will be attenuated or reduced. And then
let me just for the how do you reduce the doses? What do you give?
Well, I think about a starting dose of 15 milligrams for lenalidomide, but even with that, I think one thing we often do is we overestimate renal function in older patients. So small old people.
So start at 10 to 15.
10 to 15,
okay.
Yes.
Dr. Lonial?
Yeah, for the standard risk Lendex with the modifications that Jeff mentioned, and then for the higher risk modified RVD.
And I guess last would be Dr. Jagannath. What would you do for this patient?
I just wanted to bring to the audience attention, there has been publication about classifying patients as fit, unfit, and frail.
Right.
And what doses should be used has been reported by Palumbo in blood. Right. So I think it is a good start for people to look at. And if you look at age 80 and above are typically categorized as frail automatically by the age alone. And the recommendation is to start the patient with a lower dose of lenalidomide, 10 to 15 milligram weekly bortezomib.
Does anybody here use melphalan? It remains a standard treatment in most of the world.
I use it uncommonly. I certainly use it in the relapse refractory setting, uncommonly up front now though.
Right. Anybody?
I've used it under certain circumstances. The patient, as you pointed out, elderly patient who had a fracture or had to have radiation because of large and is now immobilized in the hospital getting radiation therapy, and then you are sending them to rehab. Bringing them back and forth is difficult. So giving them melphalan prednisone while they were in the hospital and sending them away and then bringing them back, you would have given them optimum therapy.
The very frail maybe, but the sense of things is melphalan's pretty much gone away in the United States.
Because we prefer cyclophosphamide.
Good point. Cyclophosphamide.